I'd like to introduce and welcome Jeffrey Anderson. He's the founder and CEO of Mecca Back Institute, which is a soft tissue management and corrective exercises are the foundation of this clinical treatment based on manual medicine practices. Many of those skills and tools are blended together with sound biomechanical science. Basically, if you're a layman like me, they like to avoid medications and use exercise, massage, and more to help create a stronger core, spine, and body. He's actually going to have some samples for you to use for back alignment today during Q&A if you want to try it. He'll talk for about 45 to 60 minutes, open it up to Q&A until you're ready to leave. And with that, I'd like you to join me in welcoming Jeff to the stage.
Thank you very much. I got to tell you, it's a pleasure to be here. And let me just shut this down. And I want to thank, before we get started, I'd just like to thank, first of all you for coming out. I really appreciate it. This is a great crowd. We're trying to deliver a message. It'll become clear as we go through things. But having a crowd like this is what we do the best. It's a grassroots effort because it's founded in education first and foremost. This never would have happened, though, if it wasn't for, first of all, Carrie Giaquinto, who is a student here at Bay Path. And it's just from her belief in our system and her experience with it that she's pushed and pushed and pushed every time she has an opportunity to enlighten people and help them to understand how your back actually functions and how easy it is actually to take control of it. So this is a tip of the hat to Carrie. And let me just get this sorted out here. Just a second, because Carrie's email address is up on here. Here we go. Carrie's email address is up on here. And she's available to be kind of the go-to person for us if you want more information about what it is that we're doing. She's got a great understanding of biomechanics. She's got a great understanding of back mechanics. And so if you want to reach out to somebody who can kind of facilitate a greater understanding of what it is that we do and how we're doing it and why we're having so much success, Carrie is right here on campus, so to take advantage of her. She's a wonderful, wonderful asset to us. Wendy Lecterra, I wouldn't be able to be here probably if it wasn't for her. And thank you, Wendy. And she was a big part of the process when Carrie brought this idea or what it is that we're doing to her. First of all, we speak the same language, which is really rare in medicine fields, this day and age especially. And so she was a big part of getting us here and bringing a lot of you here tonight. So thanks to her. And Brianna Sittler, we couldn't have been here without her facilitating the entire process. So a lot of thanks and deep gratitude here. I want to make sure that I don't mess this up. Perfect. Okay, so let's get to the nitty-gritty. There's a lot of stuff to talk about. And one of the things you want to understand first and foremost is back problems. Back pain is the second most common reason to visit a doctor's office. That still stands today, secondary to only upper respiratory infections. And he's frisking me. Thanks, man. I'll catch you later. I'm going to stand over here if that's cool. And Americans spend over $100 billion on back problems alone in this country. It's a crazy number. All that is treatment and diagnosis. So you go to the doctor's office, you get an x-ray, you get an MRI, you just go to physical therapy, you go to a chiropractor, you do this or you do that, dispense medications, and that's what we're paying for. That doesn't include time lost from work or loss in productivity. Now, what this information is about comes from a guy named Gordon Waddell. Got it. Gordon Waddell is a world-renowned orthopedic surgeon from Scotland. And what Waddell's information is important, and the reason it is because what Waddell noticed in his practice is that 94% of the patients that he's managing, problems were driven by mechanical issues. Whether it was stenosis, whether it was lumbago, whatever you wanted to categorize it, Waddell saw in his practice is that 94% of those problems were driven by biomechanics. What Waddell didn't know at the time is that the 5% disc disorders were driven also by mechanics. Now, Waddell didn't understand this at this point in time. Yeah, I do.
Hold on a second. They are missing it.
You guys are getting... Is it on?
It is. It's on the channel.
Channel switched. There we go. Check, 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 check. Sorry. So, briefly, what we just said is that Gordon Waddell, a world-renowned orthopedic surgeon, found 94% of his cases driven by biomechanics. 5% of his cases, which were disc disorders, now that's only because most orthopedic surgeons don't address disc issues. Most disc issues are addressed by neurosurgeons. But even some orthopedic surgeons do, and what Waddell didn't know at the time is that that 5% disc issue is also a mechanical disorder. What 1% of his cases were genetic, spina bifida, scoliosis, stuff that was not preventable. Oh, one other thing about Waddell, I don't know if I put it on this graph. No, I didn't. One other thing about Waddell is Waddell actually treated in an area of Oman in the Saudi Arabian Peninsula for a handful of years. Right around the time that that area had begun an industrialization, they found oil. And so what happened is tons of infrastructure created in a very short period of time. What changed while he was in practice there were problems that were related to many, many other disorders, to a huge increase in back issues. Now, he didn't understand what it was or why it was happening at that time. It was just something that he noted. You can read about this stuff in Waddell's book, The Back Pain Revolution. It's a good read. So, back problems are mechanical and avoidable. 85% of the population is going to experience some back pain at some point in time in their lives. Now, if you look at those statistics, a lot of those cases, they'll say resolve, 6 weeks, and then the case resolves. That's actually not accurate. What happens is those problems go dormant. And so the NIH doesn't necessarily see the follow-ups of those cases. But I can guarantee you from being in clinical practice, you'll see those cases come back over and over again. By age 50, 85% of our population has degenerative disc disease. It's so prevalent that we actually think it's normal. Okay? It's so prevalent in our culture, we actually think it's normal. What we understand now is that it's not normal, and it's actually preventable. Now, how this all starts out is we got to look at the primate pelvis. The primate pelvis, if you look at this guy's low back and his hip, is fixed in what's called a posterior tilt. Can you see that? His back is round and his pelvis is tucked underneath him. What that does means his body weight is forward, so he has to walk on his hands. The shape of his pelvis is also an issue for him walking on his hands, but he's what we call weight forward. So fixed in a permanent posterior tilt. The development of our ability to walk upright is a reflection of the fact that our pelvis gradually rotated anterior, and as a result of that, the lumbar spine had to extend. So as the lumbar spine extended and the pelvis rotated anterior, what we saw was the ability to walk upright. The problem that we've run into is that this is millions of years of evolution. This is 150 years of industrialization. So the reality of it is that we didn't evolve to sit, but it's what we're completely exposed to. And if you think about it, everybody in this room sat during the most developmental years of your life, right? When you were growing. So the reality of it is that sitting is the driving force behind back problems. It predisposes us to a series of problems that I'm going to show you right now. So a lot of people, it's maybe hard to grasp. By the same token, there's a lot of people that understand that it totally makes sense. One of the questions becomes, well, I don't sit now. Or I have a workstation. Microsoft has workstations where everybody's allowed to stand. I have a friend of mine, she has 2 MD degrees. She works on a workstation that's on a treadmill. You ever seen them? You ever heard of them? It's a horrible idea. Believe me, she's changed it. Okay, so this is the key component to what it is we're talking about. And when I speak to audiences, whether it's audiences of students or whether it's lay people or whether it's just a conversation that I have with a physician that I might be referring to, if there's no understanding of what this process is, you're missing a gigantic piece of information that's critical to understanding back mechanics and why people that do core exercises sometimes get better and then they get worse. Why stretching exercises sometimes makes a guy better and then it makes him worse. All this stuff begins to make sense. Viscoelastic creep is a principle of physics, and it happens to metals, plastics. It even happens to leather. Think of anything. What it is, it's an elongation beyond the intrinsic extensibility of the material. Okay? Did you ever see one of those shows, the how things are made, whatever? They showed it one night. It was interesting to me. They took a piece of metal and they were testing the creep effect. So two pieces of a machine grabbed onto this pipe and they were testing the volatility of the steel. And it literally did this. And you could watch the steel stretch very quickly before snap, it let go. Well, that creeping process is what happens to the soft tissue in your back when you put it under stress. The soft tissue gradually lengthens and it becomes fatigued. That lengthening fatigue is what makes us susceptible to these issues. It happens to the ligaments in your back. It happens to the discs. It happens to the tendons. It happens to the muscle. And it happens to the fascia. And all the tissue that it happens to has a specific problem associated with it. So how does it happen? The way it happens is that when we go from a standing position to a sitting position, this actually comes from a guy named Donald Newman. There's a bunch of references I can give you to the people that helped me put all this stuff together. Donald Newman showed us that when we go from a standing position to a sitting position, your body sits down on the seat pan, right? Newton's third law says a force has an equal and opposite force, right? So your body weight pushing down on the chair has an equal amount of weight pushing back, right? As the chair pushes back under you, what happens is the pelvis rolls posterior. When the pelvis rolls posterior, the spine goes from an extended position to a flexed position. Now, remember one thing. We evolved to have an arc in our back. So even if you sit down and you sit down with a very straight spine, you're in flexion. Why? Because you're not in extension, right? Neutral spine, I make the argument, is extension, not somewhere in the middle. Why? Because that's where we're designed to be. The joints are designed to be at the appropriate angles from that position. The disc spaces are parallel when we're in an arc position. When we sit in a straight position, sitting down with what appears to be good posture, that's still a flexed spine. The disc spaces are in flexion in those instances. So what happens with this little call out, what we see, is that the soft tissue, and we only used one little ligament here, the interspinous ligament, the ligament that's attached between these bones. Now, what this is a vertebrae, L4 and L5. This is the chunky piece of the bone. This is the spinal canal. This is where the abdomen would be. This is the joint that's in the back of the spine. And this ligament is between those bumps you feel on your back. Everybody got the orientation? So when you go from a standing position to a seated position, you create stretch on that tissue. Does that make sense? You see how that happens. Now, some of the ligament that's susceptible to the creeping process, this segment, this section of spine, L3, L4, and L5, everybody's familiar. I know the students are familiar. Everybody else is familiar with anatomy. This is where the abdomen is. These are the little bumps you feel in your back. Everything from the central pivot point back is under tension. The back of the disc is under tension. This ligament here that represents the front of the spinal canal is under tension. The joint capsule that surrounds the little facet joint in the back of your spine is under tension. The interspinous ligament that we saw in that last slide, and the supraspinous ligament is also under tension. This is under more tension than this or this or this. Why? Because it's further away from the pivot point, right? Everything else is under compression from the pivot point forward. So this is the front, where the abdomen is, and this is the back. Does everybody see that, how that makes sense? Layers of ligament tissue that are subjected to this creeping process. The disc is also subjected to the creeping process that we saw on that same slide. So between L4 and L5, what we see is a stretching of the disc, a stretching of the annulus of the disc. Now, if you're not familiar with disc anatomy, it actually looks like a donut. If you look down from the top of it, it's got a thick wall, and it's got a hole in the center. And in the center is this little nucleus. It's a ball of water that gets hard under pressure. And so the nucleus is acting as a pivot point, because when there's weight on it, it gets very firm. This stretching of this disc annulus thins that wall of the donut. Okay? So now all of a sudden the wall of the donut is not as thick as it used to be. Then what happens is that this nucleus is able to migrate back against that thinning wall. This is a progression that we created from our own anatomy. Now the anatomy is real, but I made this up. This doesn't necessarily happen in this order. But the idea is to gain an understanding of the way the creeping process happens. Age 22, what we see is a straight spine. What we know is that when that spine is in a neutral position, a straight position, not a neutral position, when it's in a straight position, these discs are under tension in the back. So the disc space doesn't sit parallel when your back is straight up and down. Those disc spaces are stretched in the back and compressed in the front, just like they are there. Okay? So what happens is that, say, age 22, we see a posterior tilted pelvis, which is what this is. We see stretch and tension on the back of the ligaments and the back of the disc. And then as we look at the bird's eye view of this L5 disc, it's how you get an idea of what that disc is like, right? That's that donut I was talking about. And then this nucleus is in the center. By age 37, these are random ages, okay? And you'll see how it changes, depending upon age. But this is a random age that I selected. And what we see that's important to see is the migration of the nucleus back against a thinning disc wall. Does that make sense? What we see is elongation of the ligament tissue. So it's longer now than it was before. And if we understand the creeping process, what we realize is not only is it longer, it's fatigued, meaning it stretches easier, right? Because it thins itself out and the material fatigues. And if we look at the bird's eye view of L5, look at how thin this disc wall has become. Until finally maybe age 49 or age 59, it doesn't matter. But the point in time that the creeping progression progresses such that the wall thins enough that that nuclear material can actually push itself through and you get a disc herniation. Now, if you think about it, or if you look into the statistics because you don't have a life like me, then what happens is you begin to realize that 99% of the people that herniate discs don't have an incident, meaning nothing happened. They turned their head and sneezed, or they bent over to pick up a paperclip off the floor. That is simply because it's an accident waiting to happen. Trauma doesn't cause disc herniations unless this is already prepared to go. Okay? Here, this is from Scott Bedell, and the reason I put this slide in here is because he actually has a nice image. This is what disc anatomy really looks like, much better than my anatomical version. Discs are made up of layers. So they're sheets that are connected together. That's what makes up the wall, the thickness of the disc. We call it the disc annulus. So here's a healthy disc, and we see how thick the wall is. Now, the orientation here is this is where the spinal canal would be. Okay? If there was a little bump you were going to feel, it would be back here. This is where the abdomen would be. Does that make sense? Can everybody see that? And this is the disc nucleus, obviously. See how thick that wall is? This is the disc that's been subjected to viscoelastic creep. And what happens is those layers, lamellae they're called, they break down. And as they break down, the wall weakens. What's interesting about disc anatomy is there's no pain fibers in here. There's no pain fibers until you get to the outermost portion of the wall. So people have progressions with disc herniations, and they don't even have a symptom until that disc wall starts to bulge. Crazy, right? So one of the things that we know, this statement comes from McGill. Anybody knows Stuart McGill? Stuart McGill is a biomechanical researcher from the University of Waterloo. He's probably, without a shadow of a doubt, one of the leading authorities on back mechanics on the planet. And what he's done in his lab is shown over and over and over again that you can't herniate a disc. You can't herniate that disc. A human being cannot put enough load into that to rupture it. It has to be weakened. One of the interesting things that he does is he takes sections of pig spines, and pig spines are, the anatomy of pig spines are very much like this anatomy that we have. And he'll take sections like this and he'll put them in machines. And he'll put one of them he puts in a machine that does this over and over and over again. It pushes this to end range flexion. That'll herniate a disc in about 25,000 repetitions. It's predictable. Okay? And if you make them bend this way, guess what? The disc will herniate that way. It's completely predictable. One of the things that's interesting is actually when they herniate, they actually stick to the wall. It's kind of cool. So, one of the things that we want to think about now is sitting creates a posterior pelvic tilt. Now, the greater the posterior pelvic tilt, the more tension on the soft tissue, right? So this little girl, she's probably what, I don't know, 12, 13 years old. She's sitting in what we call end range flexion, meaning she's sitting down on the beach and her back is sagging back just as far as it'll go. And its limit is based on the tension that's in the ligament that supports her back, right? Because she's not firing her muscles. She's leaning on her ligament. That's no different than me just taking my thumb and bending it like this. I'm leaning on the ligament. So what's important about this is at this age, where her body is pliable, bendable, shapeable, she's hanging in her back. We call it hanging in her back, where she's sitting in this end range flexion position. And guess what's happening, right? It's obvious. Here's somebody who we know. She's famous. She's sitting right up here. Who's sitting in a more appropriate position, right? This is a more appropriate position. But the point that we want to get from it is that it's not extension. So if it's not extension, it's in some flexion. If it's in some flexion, there's some load, even if she's queuing herself up. Okay? Now there's ways to limit the load that you get in low backs in seated positions. A 25-degree angle forward seat pan is the optimum position to decrease load, but there's still load. I'm not saying never sit again. Look at this poor guy. Okay? So now this position puts an even greater load on his back. Why? Because his center of gravity is hanging so far out. The center of gravity of a human male is right about here. So the center of gravity is hanging way out here, away from the point where he's hinging. Does that make sense? Everybody will fall into a spot where they've creeped the most. When they find where that spot is where they're going to hinge to if they move to end range flexion. And the problem is that if they hinge in the same spot over and over and over again, guess what happens? It's not like you redirect the load to someplace different. You fall into where your weakness is. Okay?
These are the guys where you actually can see the crack of the butt.
You can see, yeah. And you can, if you look at him, you can even see where he's hinging, right? It's just where the point where he changes direction. Can you see that? So what happens is, and what's important to understand, is that as this material lengthens, as this ligament, muscle, fascia, disc, tendon lengthens, what happens is the spine begins to flatten. Why? Because it has the ability to. Right? If I stretch that ligament out, then what's going to hold this thing in an arc? Nothing. It's going to fall back into where it's weak. This line is designed to represent where the center of gravity should pass through the spine. Okay? Our ability to walk upright is critically hinged to the fact that my head, the center of mass of my head, right about where my pituitary gland sits, should pass through the middle of my 5th cervical vertebrae. That's biophysics 101. Why? Because in order for the weight of my head to be balanced evenly from front to back, it has to go through this spine. Same goes for my low back. So if my center of gravity is here, that line should drop right through the middle of about L3. If we lengthen this soft tissue out and this curve flattens, the center of gravity doesn't change. Now the center of gravity is in front of the spine instead of through it. So what has to happen as a result of that? That's where our primate was. Weight forward, right? So what happens is that our bodies naturally detect this weight change. It's called proprioception. And what happens is we start to do this, trying to get our weight back. Now I'm exaggerating, but there has to be some kind of postural adaptation to this. The one you see the most is this, sway back. The other one you see is this, where they pull themselves back with their shoulders, military posture. So these postural adaptations happen because of weight distribution changes. Everybody's ability to adapt is almost all of them are going to fall into one of these two categories. Almost all of them fall into this. Swimmer's posture, sway back, call it what you want. All it is somebody shifting their center of gravity back to even out where their body weight from front to back. Okay? And if they can't do it on a curved spine because they've got a straight spine, then they have to move their center of gravity back. Now, this is what happens to the muscle tissue, and this is a technical term, destabilization by inhibition. Basically, what destabilization by inhibition means is that the spine becomes unstable because the muscles have been affected by viscoelastic creep. The muscles that we care about are these small little intrinsic muscles that are between the vertebrae. And we care about these muscles that are a little bit longer, that kind of stretch through lengths of the lumbar spine. And there's a couple others that are really critical to your stability. 4 layers of muscles in your back. The 2 deepest layers that we see here are critical to stability. They don't work like the rest of the muscles in your body. In fact, what these muscles do is they detect length. So what they don't do is create this. They don't create movement. They prevent movement. Okay? So what they do is they prevent load. Does that make sense? So with this little muscle on the left side of the area between, what, L2, L3? That little muscle's job isn't designed to bend me to the left. It's designed to guard me moving to the right. Does that make sense? So what these muscles are is length transducers. Same goes for multifidi. This muscle, we threw this muscle on this slide. This is actually from Stuart McGill as well. He's got this muscle on here, and the reason is because this is the muscle that's associated with people that have back spasms. We used to call it slip disc. You ever heard that term? Slip disc. And the reason we called it they called it slip disc when I was in college, about 143 years ago. The reason that is so important, like I say, is because McGill wants you to understand that that's the muscle associated with slip disc. If you destabilize multifidi and you destabilize these little intrinsic stabilizers, then what has to take the load? Something on the next layer. This muscle goes into spasm, the QL. We call it the QL to abbreviate it. What ends up is a guy who comes into the clinic like this. Can't stand up straight. Has no idea what happened. Scared to death. Convinced that it's got to be a disc. Why? Because it's so serious. Agonizing pain. I'll never forget one guy that came to my clinic just briefly. He had tattoos all over his back. And ER sent him up. In fact, when I was still in the clinic, ER used to send tons of people all the time. I'm like, oh, they started to recognize this presentation. Believe me, the ER doctors didn't recognize it in the beginning. After a while, they're like, oh yeah, it's another one of those guys. Send him up the street. I'm like, get him stoned before he gets here because I'm going to have to beat the guy down. And that's exactly what happened. Well, this cat who had all these tattoos on his back was scared to death. He worked for one of those companies where they fix the power lines. And he was like 6'4", and when he's in the bucket, he'd drop a tool. And if he dropped a tool, he had to push his foot up against it. So he's constantly hinging down into his back like this. When he came in, he was so rotated, he lifted up his shirt from facing the front, and I could see some of the ink on his back. The look of horror in this cat's face was something I'll never forget. These other muscles, this longissimus and iliacostalis, are also stabilizers. These are long stabilizers, though. Have you ever seen that piece of equipment in gyms where it's kind of at a 45-degree angle and you hook your heels in and the pad sets on the front of your thighs and you hang your body down and then you lever it up in the air? And the idea, some guys will even hold a plate, 25-pound plate on their chest to do it. Have you ever seen that piece of exercise equipment? We call it a patient maker. And the reason we do is because what it's doing is lengthening that muscle tissue and then putting it under load. That's why it's so critical to understand viscoelastic creep. Because without the understanding that that material, that muscle tissue, is one, susceptible to lengthening because it's been stretched over and over and over again, and it's also going to shut off. Now, those of you that are students, the mechanism that shuts this thing off is the Golgi tendon organ, the GTO. So what happens is that as these muscles get lengthened from viscoelastic creep, the Golgi tendon organ can fire. The Golgi tendon organ, remember, is an inhibitory nerve. It doesn't facilitate contraction. It shuts the muscle off. So as soon as you lengthen into that, and that muscle is susceptible to stretch, or this muscle is susceptible to stretch, it can reach enough length to fire the Golgi tendon organ very easily. And what it'll do is it'll shut that muscle off. As soon as the Golgi tendon organ fires, it's right up in here and down in here in the tendon. It sends a signal to your spinal cord that sends a signal back to the muscle that says, go to sleep. We've measured them on EMGs. And you can take somebody where the muscle tissue is firing, put them in a seated position for 5 minutes and watch it go dead silent. It'll shut right off. It's hard to turn them back on, or it used to be hard to turn them back on. The next thing that happens, so what we've got here so far is two things that happen. We got this viscoelastic creep process that creates these structural changes in soft tissues, right? This lengthening, this fatigue process. And then we've got this, whoa. Sorry about that. Where did I go? What did I do? Oh, there we are. Play. You guys are making me nervous. No, you're very nice. Nobody's even heckling me. Okay, not yet. So we've got this viscoelastic creep process that creates this lengthening, right? A susceptibility to lengthening. Structural changes in positions of spines as a result of it. We've got destabilization by inhibition, meaning those nerve fibers shut off. They continually shut those stabilization mechanisms off. Then we've got a third problem we run into called glute amnesia. Now, glute amnesia is something that was observed by McGill quite by accident. He had people forming simple squatting tasks, EMG electrodes placed in hamstrings, quadriceps, glutes, and low back muscles. And the simple squatting task, they're looking for the firing pattern of these at the time. What they saw was that as they watched different muscles on the EMG readings, the glutes weren't working. There's no glutes aren't even firing. But they're the primary movers for this action. So what had to take over? Low backs and hamstrings. Hamstrings shouldn't be doing that. Hamstrings do that. So accessory muscles taking over for functions because glutes don't work. Glute amnesia is a critical problem to understand as it relates to backs, because if this muscle doesn't drive your motion, something else has to be. This muscle creates extension in your hip, meaning your hip is designed to open. This is human propulsion, walking and running and going up a stair. If I put my foot on this step and I stand up, that's hip extension. I just open my hip. That should be done by my glute. Lifting is the same thing. Nobody's lifting from their glutes in America. They're lifting from their low backs. How about this cat? One of the reasons that we know this stuff is from studying non-industrialized cultures. The Kalahari Bushman runs his dinner to death. You can watch this stuff on YouTube. Check it out. Kalahari, just YouTube. Go to YouTube and look at the Kalahari Bushman. I forget the name of the way they hunt, but basically what it is just exhausting an animal. The animal can't continue to run as long as he can. Now, he might take 8 hours to run it to death. But that's only because it can't respirate through its body, right? It can't respirate through its skin. It has to stop, even though it's faster, and has to respirate through its mouth. So as it runs ahead and then stops and breathes and breathes and breathes, eventually it's exhausted. Then he runs up with his little bow and a little poison arrow, bang, shoots the thing, then drags it home. Now, from studying this culture, we've learned so much. One of the things you realize is when you can find Bushmen that live into the late 50s and early 60s, they don't live much longer than that. Most of them die from malaria. But the reason that it's interesting is because they don't have degenerative disc disease. They don't get disc herniations. They don't have degenerative hip disease, but they run an animal to death. They can run for 8 hours at a stretch, but there's no knee disorders. His knees, look at the size of his knees. Nothing to him. It's easy to see what he's running with, right? It's unmistakable. It comes from not sitting on it. The Bushman doesn't sit on his rear end. He squats. Same goes for the book, Born to Run. Anybody read Born to Run? The Tarahumara from Copper Canyon, 200-300 miles at a time. Ultra marathoners like we would only aspire to be. And they don't sit either. So non-industrialized cultures has taught us a ton about this. What's this posture? Swimmer's posture. And look at this. Not much going on there. Okay? So the gluteus muscle creates its action to create hip extension. That's the only way this thing will fire. Right there. That's hip extension. Can you see the orientation? Here's the little bumps you feel in your back. This is your glutes. This is your rear end. Here's the front of the hip. Okay? This is the glute complex. Here's hamstring. So what happens is that when the glute fires there, that's what it's designed to do. So it takes the leg from this position to this position. Watch Kenyans run in the Olympics. Google them or YouTube them too. Or go to FlowTrack, flowtrack.org. You can see some great footage of people running. Kenyans and Ethiopians have a distinctively different running style than Europeans and Americans. They kick way back. They almost kick themselves in the rear end. Now, a lot of people would tell you that that's because they run on hills. Everything is a hill in Kenya. That's not true. What it is it's a culture that hasn't been exposed to a great amount of sitting. Now, that's changing, but they haven't been exposed to a great amount of sitting. Kenyans are all over the place when you watch them with their arms. They shouldn't even be winning. They leak so much energy through here. But they run so pure through their hips. The next thing that happens, the fourth thing that happens, so we got three things: viscoelastic creep, elongation of soft tissues, destabilization, inhibition, glute amnesia, and then the last thing that happens from the sitting process is what's called adaptive shortening. Now, adaptive shortening is very simple. When you sit in positions where muscles are allowed to be short, and you do it consistently, they stay short. So what stays short when we sit? Hip flexors. Okay? hip flexors stay short. Short muscles are dominant muscles. And the reason they're dominant muscles is because they fire first in the kinetic chain. So when we've got glute amnesia, so this doesn't push, and adaptively short, this is only one hip flexor, psoas, adaptively shortened hip flexors, guess how we run? We run by pulling our leg forward, not pushing our leg back. When we pull our leg forward, what happens is we accentuate a posterior pelvic tilt. We feed the problem that we've already developed. And because all this stuff back in here is so susceptible to it, it gets to the point in time where every single step is somewhat of a biomechanical insult. Now, it's a huge insult to knees. Why? Because I'm kicking my foot forward, right? Which means I'm landing and I'm breaking through here. Watch people lunge. Go to the gym and watch people lunge. Walk lunge, and they'll do this. What am I doing? I'm decelerating through my knee. Can you see how I'm loading into my knee? I'm breaking right there, right across the top of my kneecap. That's what's slowing me down. So the dominance of hip flexors from adaptive shortening, and remember, rectus femoris is a hip flexor, right? It's not a quad muscle. It's not a knee extensor. It's a hip flexor. And so all these muscles feed this problem. Hamstrings also feed the problem. Tightness in hamstrings, why? Because they adaptively shorten, accentuate a posterior pelvic tilt just simply because of their attachments. And if it's short, it means it's going to pull. And if it pulls, it means we're going to accentuate this problem. So here's psoas firing. Okay? See everything lighting up. This isn't rectus, this is sartorius, but this is another hip flexor. And then there's a hip flexor in here, iliacus. And then here's psoas. What's missing? Oh, pectineus. There's another hip flexor in here, pectineus too. So what happens is there's hip flexion. The driving force for the way we walk and run. Okay, so here's our four things. Viscoelastic creep leads to 1, ligament laxity. 2, the neural inhibition of the stabilizer muscles, so that destabilization by inhibition, the firing of the Golgi tendon organ to shut a muscle off, to make it go to sleep because it's so susceptible to stretch. Glute amnesia and adaptive shortening. And what that leads to is biomechanical motor pattern changes where we don't even move anywhere near the way we're supposed to. In fact, it's almost completely opposite. So here's common movements that we see that accentuate viscoelastic creep. Okay? Because this is susceptible to lengthening because of viscoelastic creep, now what I do is all of this stuff does nothing but accentuate it. If it wasn't for that, this would be different. So the understanding of the science that we developed was well intended but completely misguided. This wouldn't bother the Bushmen, but we're not Bushmen. I mean, I'm half Bushman, but that's only because I work hard at it. This is the one that's most interesting, right? I used to do this to every patient who came into my office, one leg at a time. Drive their knee up to their chest. Hey, how you doing? What's going on? Tell me, fill me in. Without knowing that what it does is it creates drag through the soft tissue, and it creates complete inhibition of the stabilizer muscles. Destabilization by neural inhibition. Okay? Again, this girl is famous. You may want to get her autograph. Here's more of the same thing. This sit and reach, the sit and reach test is still a standard in the NFL Combine. So what a guy does is he sits down on the floor, on the field turf. He's got a box against the bottom of his feet, and there's a meter that's on the top of the box, fastened to the top of the box. It looks like one of those things a guy would measure your foot with at the shoe store. And what the guy is designed to do is to go from this position up straight and explosively accelerate toward their feet. to drive that meter as far forward as they can. That's a measure of mobility. I mean, when you think about this stuff, the fact that we've been missing out on this information, it's no wonder these guys are blowing discs. Back spasms, the single most common reason to be on the DL in professional sports, every single one of the big four. Understanding viscoelastic creep makes us understand that no matter what you do, if you've got tight hamstrings and you've got sloppy, fatigued, loose back tissue, you ain't never going to stretch your hamstrings through here. The analogy that we give to people is this is cold taffy. This is warm taffy. You're never going to stretch cold taffy before you stretch warm taffy. Does that make sense? Again, this is the stuff that becomes really, we want to get this out. We don't want to hurt anybody's feelings, but it's imperative to understand. Again, this famous lady, sacrificing her body so everybody can learn. 730 pounds of load created in a downward force on the spine from a standard abdominal crunch. 730 pounds of load. Have you ever heard of a hanging leg raise or seen a hanging leg raise? Where you hang, sometimes guys will hook their arms in the monkey straps, or they'll sit on a machine where they rest their elbows and their legs dangle and they bring their knees up to their chest. Or they bring their legs forward. That's over 800 pounds of load. Now, the load doesn't come from the fact that Carrie weighs 730 pounds. Look at her. She's a peanut. The load comes from the forceful contraction of the hip flexor groups. So the load comes from the fact that these powerful muscles fire in explosive patterns, and they create this downward force. Something that's easily measurable. And everybody that found out about it when this first came out, everybody wanted to reproduce it. So it was one of those studies that nobody believed it. And then once it was tested over and over and over again, it was just like, this is crazy. So when we look at athletes, I used to wonder about athletes. One, because the athletes that I had in my clinic were in worse shape than the guy who was doing nothing. And as much as I was trying to berate the guy, I was telling Nani earlier, berate the guy, get at the gym, get to do something, go play tennis, go do something, but you got to get out, you got to get fit. And the reality of it is these guys are in worse shape. That's all they do is work out. Backs, hips, knees, shoulders, it didn't matter. So the idea of creating an understanding that the sitting process as they're competing in sports is critical to back health. If this guy goes out to the field and warms up, even if he does everything appropriately, the way he should, sits on a bench, most of them will shut their stabilizers off in about 5 minutes. That's all it takes. Now what McGill showed with it is, no, not McGill, I apologize, Greenier showed that it would take about 30 minutes of doing this, walking around, pressing your palms together to create some activation in those stabilizer muscles. So the reality of it is that I got tons of people that I run into on a consistent basis that are like trying to help themselves. And they just have no idea. That's why this information is so critical to get out. Our objective is to make this common knowledge in 5 years so that everybody understands that we don't do this anymore. Why? Because it comes at a penalty. And we've got tons of options. We do tons of research, finding exercises. We develop a significant amount of exercises. And we've got alternatives for all of them. Better alternatives with no back penalty. So the fatigue from the creeping process, the instability, glute amnesia, and adaptive shortening lead to these obvious motor pattern changes. So that even those athletes that are participating on the field, they're running and braking and turning, change of directions, jumping, all through inappropriate motor patterns. So our system was designed to counteract these elements. And I'll be honest with you, when I was working in the clinic and I started to work with a lot of athletes, I knew that there was problems with sit-ups. I knew there was problems with leg raises. I didn't understand how it happened, but I just knew that there was something, mostly because the significant portion of them complained about them, and I had the same kinds of experiences. The development of the system was very much from the understanding that I began to realize that these guys are not going to get helped by just me treating them alone. I need to do something to change the way that they train. And when I started to get strength and conditioning programs from Anaheim Ducks, New York Islanders, Brown University basketball programs, tons of strength and conditioning programs for elite athletes, you began to see common threads. Everybody's doing the same stuff. Now, the Islanders might say, yeah, no, ours is a core-driven system, and it very much is, but it's a biomechanical nightmare. You know? So the concept that I developed in the clinic was creating an understanding that we can't chase mechanisms of injury. And the reason is because most of the time there isn't a mechanism of injury. Now, some instances there is, but a lot of times, even if there is a mechanism of injury and we can treat that process, you still need to do something to change the way that this guy puts himself in a position to predispose himself to the injury in the first place, unless it's some external trauma. Does that make sense? If it's him breaking himself down, or him pulling a hamstring because he jumps, that's his issue, not somebody else externally injuring him. So we've got to find the solution to the problem. So we created an idea where we looked at an acute back episode. And the way we would talk to people in the clinic is that the acute back episode means you've fallen off the edge of a cliff. We're going to treat you today, and what we're going to do is that treatment is going to bring you up to the top of the cliff. That's what it's designed to do. Today, tomorrow, but we're going to get you back to the top of the cliff. From that point, we focused on an objective of getting them as far away from the edge of the cliff as we possibly could. So we call that adaptability. And the idea is understanding that there's three things that have to work in synergy in core and spine mechanics to develop adaptability. That's motion in the joints, elasticity in the soft tissue. Elasticity in the soft tissue is different from flexibility. I had plenty of yoga teachers that had plenty of issues. Tremendous flexibility. In fact, some of the flexibility may not even be that well balanced. I'm sure that that's not too hard to grasp. Elasticity, on the other hand, is a textural component. When you take spasms out of muscle tissue, when you treat it appropriately and allow circulations of fluids and blood into soft tissue, what you do is you create a physical change that's easily perceptible by the practitioner or anybody who's touching it on a regular basis. Back spasm patients come in and their backs feel like clay, lacrosse ball texture. What we were doing was shutting that mechanism off that's creating that textural change, and what you'd see is healthy backs feel like a racquetball. Soft tissue that's healthy has an elastic texture to it that's pliable and resilient. Unhealthy tissue feels like clay or, like I say, a lacrosse ball. You see it a ton in backs. And then core stability or core strength. Integrating these three elements is how you maximize adaptability. The reason that it's so important is, first and foremost, I had patients that would come to my office that were already abandoning the notion that they were going to get any resolution. They just came in, just patch me up, man. This is how this works for me. I'm going to live with this forever. Patch me up. I know what I need. Empowering people to understand that, you know what? We understand this problem. I had one woman, I'll never forget her. She broke into tears. She was so mad at me when I explained this stuff to her. And she's like, every time I talk to one of you expletive guys, I get a different answer.
It's true, though.
The frustration and the anxiety and the defeat that people have if you see people that deal with long-standing back problems is the driving force behind why we do what it is we do. These people are desperate. And yet, when you show them this information and you get them to apply the principles correctly, you see complete resolution. Unwinding the negative impacts is key. Understanding the mechanisms that we saw, those 4 things that we talked about, and then understanding that what we're basing this stuff on today is not fiction. It's not theory. It's hard science. And the science is reproducible. So the protocol, unwinding these negative impacts, goes like this. We unload the passive soft tissues. Passive tissues are ligament tissues, right? Fascia is passive tissue. Even though there's a little bit of contractile ability to it, it's mostly a passive tissue. So the unloading of the disc annulus, which is a passive tissue, meaning they don't create their own contractile forces. Unloading that ligament tissue is critical. And what happens is that ligament will remodel itself. We have plans for a large study. And one of those things that we're going to look at is the remodeling of ligament tissue, just the same as you see in dental stuff, or in orthodontics. Activation of the stabilization mechanism. Our system, because we create active extension, will turn those stabilizer muscles back on. We haven't been able to test it with EMG, but that's another plan that we have. The reason we know it's happening is, one, the change in the patient is night and day, or the individual is night and day. The other reason that you know it's happening is because you'll see when the muscles turn on. It might take 3 days, maybe 2. Sometimes it takes a little bit longer. It depends on the status of the individual. But what you'll see is flat backs, where there's no semblance of a curve. It looks like a board. Now all of a sudden you've got muscle tissue that's fired up, and there's a canal there. There's a visible indentation where the spine is. That's not the curve coming back. Can't come back that quick, and probably never comes back. What it is those little paraspinal muscles that begin to become activated. All they are is turning on. When they turn on, they get a little thicker. And then opening at the front of the hip girdle. Okay? So using biomechanically sound exercises that don't create a back penalty. The single biggest penalty that we can create is a posterior pelvic tilt. Now the irony of it is that I taught people to posterior pelvic tilt. I made a living at it for 15 years. I did what I was taught. The irony of it is that as I was strengthening this system, what I didn't understand is I was penalizing this at the same time. So you give people strength here, and understanding how this system works, this muscle tissue that wraps around your waist, right? Rectus has nothing to do with it. You can take a 6-pack muscle, throw it away. You see patients that have it harvested for a lot of different surgeries. That's one of the first things you'll take. The muscles that we deal with, core, move in this direction, right? Transverse abdominis. That doesn't create this movement. It's a brace. Internal and external obliques, they blend together to form a common tendon that wraps around your back. It looks just like a corset or a back support. The problem with it is the corset spans the entire length of the lumbar spine and part of the low thoracic spine. That's a big region to support. It doesn't do anything in between the segments. That's what the little intrinsic stabilizers are for. So you can make the argument that if I make this strong, but I haven't turned on those little stabilizer muscles, is that to my benefit? If this is strong, but there's nothing balancing it on the other side? The understanding of strengthening quadriceps in an athlete without equally strengthening hamstrings is, we got that figured out 15 years ago. This is nothing more than explaining the understanding why back problems are such a struggle. Mackenzie extension exercise. Love this guy. Way ahead of his time. Way ahead of his time. The problem with it is that what Mackenzie didn't understand is why it worked sometimes and why it didn't work other times, which is why a lot of times you had 2 factions. Williams' flexion models and Mackenzie's extension models. Interesting thing is you'd never do this for stenosis, right? contraindicated for stenosis patients. We treat stenosis patients every single day with extension. The difference is that we're creating a force that's coming from this direction. Okay? So the shortcomings of Mackenzie's extension were the fact that if this material is stiff, talk about famous, look at this cat. If this material is stiff and rigid because of tightness in muscle tissue, reactive spasms, scar tissue that forms, and I put myself in a simple situation where I'm going to let my back sag, how predictable is it that it's actually going to create an appropriate arch? Right? One of the reasons that you can't do it with situations where you see what we call facet syndrome, where there's loading in the joints in the back of the spine. It's contraindicated. Why? Because already too much arch is what the theory is, but it's not. A sway back is not too much arch. It's a flat spine that's reclined. It's too much arch maybe at L5S1, but the spine is not, the lumbar spine is not arched. It's flat as a board. So you could see why, if I stand in a sway back, why Mackenzie's protocol may irritate those joints. So this guy was way ahead of his time. Way ahead of his time. He was the first guy to say, you know what, we live in a flexion-dominant culture. Everybody's here. Let's open them up. In fact, at the time of Mackenzie, he was from Australia. They were dealing with sheep shearers who did this for a living. At that time, it was fashionable to prophylactically remove your discs so you didn't lose time from work. Because why? Everybody that did this for a living was blowing discs like there's no tomorrow. That's no different than our guy that was sanding the floor, right? We live on Cape Cod. Try this. Dig your rake into the ground and then pull to dig clams for a living. So Mackenzie, way ahead of his time, we owe a tremendous amount of credit to Mackenzie. But we also have an understanding of why there were some flaws in the approach. So one contraindication that we have, the one single contraindication that we have, like I say, we treat everything with one protocol. Sounds crazy, right? Sounds impossible. The reality of it is that it works, and it works because what we're doing is unwinding those negative impacts. We're giving the spine back what it needs. The only contraindication we have is radiculopathy, which is a radiating symptom down the leg, one or both legs, that you can't make an adjustment to the position of the wedge that shuts it off. I'm telling you, when you've got a situation where you can't shut off the radiating symptom in somebody's leg, they're going to surgery. Okay? In fact, we qualify a lot of people for surgery today. And the reason is because if they can't tolerate the protocol, they're not going to get better. What are you going to do? Put them in flexion-based exercises? That's how they get the problem in the first place. So one of the things that you see clinically and you guys can check this stuff out. You can see it all the time. We encourage people to look. One of the funnest things to do is to look for this, interspinous tenderness. Find the area where somebody creeps. I guarantee you, every single person in this room, if you're to lay down on your stomach, I can find a spot where there's a gap in your lower back. And when I push on that gap, two things will be apparent. One, it'll have a boggy texture to it. And two, it's going to be uncomfortable. It's going to hurt. It's going to be pain sensitive to pressure. And the reason it is because the supraspinous ligament, the ligament that's most superficial, is pain fibers in it. The interspinous ligament doesn't, but the supraspinous ligament does. Thick waist through the side. Backs collapsing. Backs that are in spasm. Most people that have backs in spasm will present in these different positions. Some of them will present where they just slightly bend forward. It's called antalgic. And that antalgic position, what it does is that even as the individual tries to stand them up straight, if they look at themselves from the side, they'll look thick
through the waist. Sometimes their belly will even protrude out because they're trying to figure out how to get their weight back. You can see it all over. It's really interesting, and it's really interesting because it's completely reproducible over and over and over again. And then again, don't be fooled by sway back. This is not hyperextension in your back. This is a flat back where you're shifting your weight back. It's a complete misdiagnosis. So the wedge that we developed is designed to do a number of things. And what we see is that studies that have been similar to our product, this Iowa study was a great study. They basically took people and they put them in flexion for a short period of time. I think it was 20 minutes. And they had them sit. And then what they did was they measured the height of their discs with what they call standiometry. It's a type of MRI. And so what they saw was, they checked them ahead of time, and then they had them sit for 20 minutes, and they checked them again. What they saw was a compression of the disc and a loss of circulations of disc fluids. Disc fluids are what keeps the disc healthy. There's a limited blood supply to the outer layers, but the rest of the disc is maintained its health through circulation of fluids. And then they put them in a hyperextended position. They used an air-inflated bladder. Hyperextending means they arched them up in an excessive amount. And in 10 minutes, they had checked them again, and they had rehydrated their discs and restored their disc height. The lumbar curves improve, but they improve slowly. And the reason is because even though we're driving them into extension, you still sit. So it's not like having braces on where there's a constant steady force there, right? It's more like having a retainer. And you pop it in, and then you pop it out, and then you pop it in, and you pop it out. And increasing the elasticity of the supportive soft tissue. This is the thing that becomes the most apparent. You guys that are students here, take your friends and lay them down on any surface except a bed, but put them on a stiff surface and just motion their backs. Just take the heel of your hand and push down and up and get a feel for the springiness or lack of it in their low backs. Have them go through our protocol for a week, and what you'll see is that thing gets resilient and rubbery and pliable exactly the way it's supposed to be. The difference between good backs and bad backs is that stiffness. If that thing is stiff, there's no way for it to adapt. So it's basically what we're doing is reversing the creep effect. So this is the cliff notes on how the system actually works. So here's the thing that we saw Carrie doing earlier. A standard, we see the thoracic spine moving into flexion. This is actually a section of a new animation we're in the process of creating. And what we see is, here's the abdomen, right? Everybody got the orientation? See the pelvis here? This is the thoracic spine, so the head is over here. So what he's doing is what we call a lift, a abdominal crunch. And what we see is the contraction of this muscle creates a downward force, creating lengthening of those intrinsic stabilizer muscles, right? What we know from viscoelastic creep, they're already too long already. So even though we're creating contraction of this for the benefit of that corset, it's coming at a penalty, shutting off the stabilizers at the same time. What would happen if you fired your quad but inhibited your hamstring at the same time? It's a complete imbalance. Not to mention the fact that we don't want to accentuate this posterior pelvic tilt because we already know what got us in trouble in the first place. Our system is very, very simple. We take this whole situation and we put them in an extended position. This material is what makes the difference. It's made of a blend of rubbers and PVCs and all kinds of cryptic stuff that I'm not allowed to talk about. But what happens is that the contractile force is exactly the same. The spine pushes down against the wedge. The wedge pushes back. The cells in the wedge are not like foam. What foam does is the cellular wall collapses. Okay? Memory foam. Think about memory foam, right? If you could see the individual cells, what happens is the cell wall collapses. And then when you release the pressure on it, the cell wall comes back. Our material collapses and then opens back up. So what it gives you is push. This is the reason that hard foams like EVA foams don't work. We've tested them. The shape matters as well. We created one of the early prototypes we called the foam dome because it was designed to reproduce the arch. We don't want to reproduce the arch. What we want to do is have weight hanging off the end of this here and weight hanging off the end of this here. And if we activate the core at the same time we can create this, we create a shortening of those muscles. Those muscles are strengthened, again, not by putting weight in here and doing this. These muscles are strengthened from resisting this. So what's happening is this is pushing, allows these to shorten, and as long as you don't feel any discomfort in your back, the force that's pushed into here is an adequate or manageable amount of force for those little muscles. Now you're strengthening them. Okay? No back penalty. There you go. Another famous individual. So the protocol that we developed, very, very simple, very straightforward. We want to open up the hip girdle. We stretch our hips for the benefit of our back, not your back. Why? Because we know stretching your back is bad news. In fact, I've been doing this so much now, I feel it. It's always important to understand that the hip girdle needs to open, not the back. Biomechanics 101. This is designed to be mobile. This is designed to be stable, the knee. The hip is designed to be mobile. The back is designed to be stable. The thoracic spine is designed to be mobile, and the shoulder is designed to be stable. Most people are opposite in every single region. So we lie in the pigeon pose. Pigeon pose is a great pose because it's effective at opening the hip girdle. We used to use active isolated stretching or PNF or give people stretching exercises to do on their own. And it takes a while to stretch everything around a hip girdle. This will stretch it in 3 minutes. So we do a minute down here to open up the hip girdle, and then 20 seconds to fire the glute complex, open up the front of the hip flexor on the opposite side, activate spine stabilizers, and we integrate this together with activation of the lat muscles because those represent what we call slings. Lying on the wedge for 10 minutes. It's a simple protocol. That's all there is to it. We do that for the overwhelming majority of our clients. We call them clients, not so much patients, because we do it in a physical fitness setting. And most of the problems will resolve in a very short period of time. When we were still doing this in the clinic, the rule used to be you do this protocol for 2 weeks. If after 2 weeks you're not resolved, then we can talk about implementing some treatment because maybe it's necessary to break down some soft tissue or maybe it's necessary to address some other complications that you might be having here. That's when we instituted treatment. We refer them out now. And then the other way to approach it is to do 10 minutes of exercise. When you do 10 minutes of exercise, you're guaranteed to get a better result. Why? Because now you're strengthening your core and you're getting this pressure push in your back at the same time. So core strengthening, completely different. The nice thing about it is it feels completely different. And we'd like to get a couple of you guys up here. Huge variety of exercises you can implement. This is what we call a combo crunch, just one of the simplest movements. Look at how far she's moving. All she's doing is her shoulders aren't even come off the floor. From this position to this position. So, yeah, all she's doing is lifting her head and her shoulder girdle. The only thing she's doing is she's just tightening her abdominal wall. Her legs up here in the air are already making this fire. So she doesn't need to move very far. The reason we like this exercise so much is because it really is kind of what this does, which is just brace, right? It doesn't really create motion. We have no sound. But this is our animated video we created.
The spinal flexion creates a backward pelvic tilt that simulates sitting with poor posture and rounding the lower back. This is a major contributor of lower back pain. Studies show that the force generated from the abdominal crunch generates approximately 730 pounds of downward force on the lower back. In addition, the abdominal crunch compresses the fronts of the vertebral bodies, forcing increasing pressure to the back of the discs. This weakens the discs and increases the potential for disc herniation. With use of the back wedge, the hip flexors still contract, but the damaging force from spinal flexion is prevented because the lower back remains extended. Because the lower back is supported in an extended position, the force that is normally exerted on the lower back is now transferred to the abdominal muscles. In addition, the abdominal muscles must work through a larger range of motion, creating a more forceful contraction, so abdominal strengthening is more effective. The resiliency of the back wedge responds to the force of the exercise effort and the body weight by creating counter pressure, which enhances the natural elasticity of the spine. The traditional abdominal crunch, when performed on the back wedge, is therefore more effective at conditioning the abdominal muscles and removes the risk of any injury to the lower back.
Okay, so basically what we do is we take a preventative approach to this. It's a preventative approach in the sense that people are proactive. But as far as traditional prevention is concerned, what we want to make sure people understand is that we use it for treatment. I mean, we use these types of approaches with wedge stuff is all we do for backs. Doesn't matter what the diagnosis is. We've seen it all. But it's more than a preventative approach. It's a treatment. We can use it for treatment. That's one thing that we want to make sure of, because sometimes when you talk to people about prevention, everybody's like, yeah. I know you're supposed to pre-prevention, okay? It's not rhetoric. It's a completely different process. So, but the message here, and this is the message that we often tell people, strengthening this is a great idea. You got to do this. But it's a little bit like brushing your teeth with a hard bristle toothbrush. Okay? You get your teeth clean, but it comes with a penalty. The notion of not having some type of protocol for your back, because we're all exposed to this problem, and the statistics speak to it. The only 15% that's not reporting themselves to the National Institute of Health are just not going to the doctor. They're already fed up. So the idea that if you're not approaching your back problem proactively, then, what are you doing? Going to see somebody to get fixed. Treatment is necessary. Treatment is a wonderful thing. But what we want to do is we want to marry it with these biomechanical concepts. Okay? Maintenance, exactly. So that's that.